Hi, AHCJ. I hope y'all are well. Thank you for joining this webinar, looking at what 988 is achieving, where its challenges are, etc., since its launch in July of last year of 2022. Our panelists today are Heather Saunders and Vince AHCJ. Vince will be joining us momentarily. Heather is a social worker, and for the young journalists amongst us who may not know, social workers are also counselors and clinicians in assorted kinds of practice. Heather also is a fellow and researcher at the Program on Medicaid and the Insured at the Kaiser Family Foundation. Her work focuses on behavioral health policy, mental health, workforce shortage, and healthcare delivery for people with disabilities. She will be our leading speaker, of course. Vince AHCJ is president and CEO of Mental Health Colorado, and prior to that was executive director of the Equitas Project, which has since folded into Mental Health Colorado. It's an initiative to disentangle mental health and the criminal justice system, i.e. to get fewer people who are in mental distress in the backseat of a cop car and more of them into treatment. We're going to go ahead and start off with Heather. Thank you, Heather, for being here.
Sure, it's great to be here. I'm sharing my, let's see. All right, do you see my screen up? Okay, great. Well, it's great to be here. I'm Heather, a postdoc at KFF, and it's really an honor to talk about this topic with you today, about the first year of 988 and the Suicide and Crisis Hotline, as well as the changing landscape of crisis response. I work at KFF, which is a nonpartisan organization that provides unbiased, independent data to help inform current policy discussions. And as such, we're a resource to you, to the media. We recently changed our name from Kaiser Family Foundation to just KFF to highlight that we're not connected or associated with Kaiser Permanente. In today's presentation, I want to share three main areas with you. I want to talk about the what and why of 988, what we know about 988's first year based on available data, 988 and the broader crisis response and how they connect, and then I'll leave you with a few questions that are on my mind. Provisional data for 2022 for suicide deaths was just released, and it showed that suicides reached a record high in 2022, with over 49,000 lives lost to suicide, and many more people experiencing suicidal thoughts or attempts, and even more with or undertreated mental health or substance use conditions. The rise in suicide deaths was driven by increases in firearm suicides, which is the most lethal method of suicide. So now I want to move into the what and why of 988. So what is 988? 988 is the number to reach the 988 Suicide and Crisis Lifeline. This was previously known as the National Suicide Prevention Hotline until this past year in July of 2022. 988 is available nationwide, 24/7 to anyone free of charge. How does it work? It's a network. Oh, sorry about that. It's a network of over 200 local call centers with a national administrator. When people call 988, that number gets routed to the national administrator, and then that call is sent based on the caller's area code to the local crisis call center that's closest to the person. If for some reason the local crisis call center can't answer the call, say that the wait is too long, the facility is too busy, over capacity, then that call gets sent back to federal overflow facilities, which is kind of the safety net system for 988. So it'll get answered by that facility. So why 988? 988 is easy to remember. It's easy to remember in a state of crisis as well. And that's a similarity between 988 and 911. And one of the main reasons that the appeal to change it to 988. 988 is also a step towards a system that provides a behavioral health response to a behavioral health emergency. And that's moving away from the historical response that has been provided by law enforcement and emergency departments. And it's also a core component of the crisis response continuum, which SAMHSA identifies in 3 parts: someone to talk to, that's crisis call centers or 988, someone to respond, which would be mobile crisis, and a place to go, which is a crisis stabilization facility. So next, I want to talk a little bit about key statistics for 988's first year. As I mentioned, 988 was launched in July 2022, so it's been a little over a year since it was launched. And I'm using data from May 2022 prior to launch and comparing it to May 2023, which was nearly a year since launch. So this slide shows answer rates for incoming calls, chats, and texts to 988. National answer rates, as you can see, improved dramatically from May 2022 to May 2023, especially for chats and texts, which had pretty low response rates prior to 988's launch. As of May 2023, the total answer rates are at 93%, up from 70% the year before launch. What's not shown on this slide is the number of incoming calls, texts, and chats, which increased dramatically. In its first year after launch, 988 handled over 4 million contacts, over a 30% increase compared to the previous year, and an additional million contacts for the Veterans Crisis Line. And the Veterans Crisis Line data isn't shown because it's not publicly available. Another area not shown on this graph, but worth mentioning, is the number of texts that 988 received after launch. Incoming crisis text increased more than 8-fold and represented the fastest growing mode of communication. But as of now, still account for a smaller share of total incoming crisis outreach compared to calls. So we know that volume increased, outreach volume increased, a lot more incoming calls and text. We know that the answer rates improved. And while these 2 things happened, another thing happened, which was the wait time decreased. So wait times decreased from about 2.5 minutes down to 35 seconds a year after launch. So as I mentioned before, the way that 988 works is it routes calls to the caller's closest local crisis center, and that's based on the caller's area code. So why do in-state answer rates matter? Well, local call centers have better access to resources in the community. They know what's available. They know if there are additional crisis services in the area, like mobile crisis teams or crisis stabilization facilities. They have a sense of what kind of outpatient care is available, what other resources are available. And since they're familiar with these resources and able to refer appropriately, they should be able to better provide this information than people that are located out of the local area at federal overflow facilities. So as you can see, even though national answer rates were quite high, the average in-state answer rates across states varied quite widely. They varied from a high of 90 to 98% in 14 states to a low of 55 to 69% in 5 states, including DC. So those are some questions. We can answer some questions about 988 using that data, which is publicly available on the Lifeline website. However, there's a lot of questions that we have that we can't answer with the data that's currently available. Some of the questions that we can't answer include how many call centers are there total? Because there are call centers that are not affiliated with 988. How many of these are affiliated with 988? How has this grown in recent years? When people call or text or chat, What are the reasons for reaching out? Are they feeling, is it feeling suicidal? Is it PTSD reasons? Is it anxiety, self-harm, basic needs? What's happening there? Are people getting connected to the outpatient care and other crisis services they need? Because ideally, contact to 988 doesn't just stop there, but people get connected to subsequent sources of care. And then what is the quality and user experience with 988? What do people think when they call in? Do they feel comfortable talking to the person on the other end of the line? Does that vary by geography, by race, ethnicity? Are 988 counselors delivering culturally competent care? So we can't answer a lot of those questions with the data that's available at a national level, but some states are taking it upon themselves to do a better job of answering some of these questions. So what I have on the right is a screenshot of South Dakota's data dashboard, and that answers a lot of the questions that I just mentioned, although not all of them, but it answers questions like presenting concern, why did they call? What happened after they called? What was the contact method? Was it transferred from 911 or someone else? What are the demographics and geography and other questions like that? So what you're looking at right now is SAMHSA's framework of an alternative pathway to how most places in the country currently handle suicidal thoughts or behavioral health crises, which is typically responded to by emergency departments or by law enforcement. And that's how it works right now. But 988 is not just a number, it's actually one part of a crisis system that SAMHSA hopes to build out. And this crisis response system provides an alternative pathway. Instead of calling 911 and going to the emergency department or interacting with law enforcement. And what this pathway looks like is a person in crisis to the left could call 988 instead. And then 988 would counsel them through their crisis. Research shows that the majority of crises are de-escalated at this point, and only a fraction of those need further crisis response. So the majority can be handled on the phone, and they can be connected to outpatient care or other resources from that point. But for some people, they need someone to go out to respond in person. That would be kind of similar to emergency EMS services, but for mental health. These are called mobile crisis teams. When mobile crisis teams get sent out, most of the situations are addressed on site and they don't need further escalation. But there are some people that need somewhere safe to go. And for those people in this crisis response continuum that may be emerging, those people can go to crisis stabilization facilities where they'll receive specialized behavioral health care from people who are trained to provide that response. So this crisis response continuum is intended to improve quality of care and use fewer resources. Initial studies looking at cost and quality of this continuum compared to the usual care of law enforcement and emergency departments suggest that this continuum is both life-saving, or it's cost-saving, and provides a higher quality of care. So infrastructure for these systems is emerging. It's not available in all states, not available in all areas, and the responsibility for building up this infrastructure is not at the federal level, but at the state level, although there are some federal opportunities for implementation. So similar to 988, there are a lot of questions about crisis care that are unanswered due to its emerging nature. For example, what states have mobile crisis teams available in crisis stabilization facilities? Are these available to all people statewide, or are they just mostly located in certain metro areas? How do the systems connect with other parts of healthcare, other social delivery systems? And then a big question is how to finance these systems. So one payer has actually started to provide some coverage of these services, and that payer is Medicaid. Medicaid about 40% of Medicaid enrollees have a substance use disorder or mental health condition, which is higher than other coverage types, but the prevalence in other coverage types is still quite high. Medicaid is also the single largest payer for behavioral health services, and as such, Medicaid has the potential to play a role in financing crisis services. So in a survey to Medicaid programs, to state Medicaid programs, we asked them what crisis services of a subset they're covering. And 45 states, including DC, responded. We asked them if they're covering crisis call centers, mobile crisis, or crisis stabilization units. States told us that the majority are covering one or more of these crisis services for fee-for-service adults, but 75% don't cover all three, and 4 states don't cover any of these services. The states that responded said that they report a variety of challenges with crisis service implementation, including workforce and geography challenges. So what to watch? As I brought up, there are a lot of questions that are emerging from this area that's quickly growing from the first year of 988, from the emerging crisis services that are connected to it. Some questions are around data. So what's happening with suicide rates and crisis indicators of like emergency department utilization for people that feel suicidal or who have self-harm behaviors. What about 988 performance data? Is it becoming more available? How about funding for 988? What's happening there? What states are taking up telecommunications fees? What are these fees paying for? What other ways are these services being funded through state mechanisms or other mechanisms? And then the insurance piece of funding. What payers are covering what crisis services? And are these being picked up by other payers like commercial or Medicare? Another big question is 988 linkages, crisis, and then community awareness, including individual awareness. Right now, only 13% of people know that 988 even exists. And that's important too for the larger community to know that 988 exists, because they're going to have to interface with emergency departments, with hospitals, with social service agencies, and with law enforcement. Another part of the linkage that's that might be important to watch is bed registries, how 911 connects to 988, whether 988 has the capacity at local call centers to dispatch mobile crisis units like 911 does for ambulances, and then whether they can schedule outpatient appointments. And there's also population-specific initiatives that are worth paying attention to. That includes LGBTQ populations, and then maybe special outreach for youth or elderly. And then also, what is the equitable reach of 988 look like, and is 988 providing culturally competent care? So as you can tell, the first year of 988 has several positive statistics, and there's some state variation in performance and a lot of questions. Thank you.
I'm sorry, I was muted. Thank you, Heather. We so appreciate that. Hey, Vincent, it's good to hear and see you again. You have the floor.
Hi, nice to see you. Nice to see you both, and thank you, Heather, for that great presentation. I think I just want to offer some reflections on how 988 is rolling out in Colorado, and but also about what it means for what we think we need to see in terms of a transformed approach beyond crisis response in our communities. What I think that we tend to forget, because we're so familiar with 911 and its convenience, is that while 911 was conceived in the late 60s and designated as a number, we didn't get to the point where over 90% of the US have availability to dial 911 until the year 2000. So it took over 30 years of local rollout before we arrived at the fully established emergency response system that we're so accustomed to. And so I think that it's important for all of us to just remember that it is going to take some time for 988 to become the thing that we need it to be. And part of it is, what we were as Mental Health Colorado and very excited about when we supported the ballot measure here in Colorado to create a tax basis for funding a broader crisis system, was that by creating this number, what we're doing beyond establishing the crisis system is creating a new framework of understanding for people around the country to elevate our literacy when it comes to realizing that there is such a thing as a mental health crisis that is distinct and requires a distinct response, and to really drive home that difference between the sort of response that might lead to law enforcement engagement and criminalization of someone with a health need, and create a safer space for responding to those kinds of health needs. So getting to that place where we have not just a functioning crisis system in localities all over the country, and as Heather was pointing out, in some places it's coming along much more handily than in others, and there will remain disparities there. But understand that this is something we need. This is a great thing that we've got some shared focus on, but locality by locality, we've got a ways to go before we have a shared cultural competency with regard to the broader questions around mental health. While those of us who work in mental health advocacy have a clear understanding of the extent to which our jail and prison populations reflect an inadequate healthcare system in our communities, we don't yet have a broad cultural understanding of that, and getting to a healthier place in terms of being able to distinguish between criminal behavior and behavior that can lead to criminalization is a work in progress that all of us have to be patient with as we're making our way. I think that when it comes to the 988 rollout in Colorado, and to some extent this reflects on the national experience, by putting the notion of a thoroughly robust crisis response system that leads to pathways to healthcare out there as our north, that's a very important gesture for us to be making, and is well in keeping with the function of the federal leadership in these kinds of initiatives. But when it comes to local implementation, we're confronted in Colorado. We have a funding source. We passed a tax that is now part of people's telephone bills through exactly the same kind of mechanism that we have funded 911 response. And so there is a recurring available font of funds for this, but fully populating the crisis system runs into the logistical challenges presented by a state characterized by vast rural and frontier regions with gigantic distances that are kind of inconceivable for folks who live in smaller East Coast states. And it's a workforce question. We were expected in the state of Colorado to add something like 130 additional crisis responder dispatch workers to our crisis system. And that's a process that began over a year ago. But to the best of my awareness, we remain with something like 130 vacancies and have real challenges in terms of filling those spaces. So that gap between what we need to see happen and getting there is truly significant. And there's a lot of factors involved in the workforce shortage that is an issue across the behavioral health landscape. I think I wanted to mention as well, I really appreciated Heather's slide that showed the various stages from crisis through the intercept points with a system. And, I'd be remiss if not to say that we are absolutely in a crisis mode as a nation. We are in a vast public health crisis when it comes to mental health. There's a pediatric state of emergency when it comes to mental health. So we are undoubtedly in crisis mode, but to the extent to which all of our efforts and resources remain focused on the crisis response, we're kind of doomed, I think, to remain in crisis response as our population health conditions deteriorate or at risk of deteriorating over years to come. If we're going to get out of permanent state of crisis response, we need to simultaneously invest effort and resources into health promotion and prevention and creating greater access points to much needed care in the community for people so that we're not waiting until crisis occurs before a system of care has an opportunity to intervene. And creating that, what the public health folks will refer to as the upstream interventions, that is a tall order in most states around the country that have very little understanding of what people need to have a better chance of experiencing greater mental health. And it comes down to the kinds of fundamental things that we are slow to address in most communities, such as available supportive housing. People are at too great risk of losing their housing. And people are at too great risk of not being able to afford housing in many of the communities where they want and need to live based on what they are able to earn, especially given health conditions that may be making it difficult for them to maintain that kind of sustainable employment. Where we do house people readily and employ them are unfortunately in jails and prisons. And we really urgently need to become a community that prioritizes the health and well-being of humans in community and finds a way of housing and employing individuals in the community. So that jail and prison are not the most reliable place in America for Americans to get their health care. I want to say a little bit about the substance use crisis right now and the opioid epidemic as well, where in most states we have a persisting bad habit of criminalizing individuals with these kinds of addiction conditions. And it's got a 50 or 60 year track record of not being productive in terms of human health and well-being. And it's time to be a bit more enlightened and progressive in terms of practicing some meaningful harm reduction. And while on the one hand, in the state of Colorado, we have had to acknowledge it as a win to embed medication-assisted treatment for substance use conditions in our jails and prisons, the very unfortunate fact of the matter remains that jails and prisons are where we have most effectively made medication-assisted treatment available. Access to that kind of state-of-the-art care to intervene in an addiction is very scarce in the civil setting. And there again, what we've done is we've created a set of conditions where criminalization is a pathway for an unmet health need. And that is like as counter to what I always thought American principles were meant to be as could possibly be, that the land of liberty is the incarceration nation, and it's largely driven by healthcare access scarcity in the civil world and building up our jails and prisons as the place for that. And on that front, I would just want to point out that in Colorado, anyway, the current state of regulatory affairs is such that emergency departments and pharmacies and hospitals and primary care providers all have the credentialing they need to be able to be access points for medication-assisted treatment. And yet they do not practice in that way. And what we really need to advocate for is a broadened scope of practice so that people who need support to alleviate their addiction to these super powerful pharmaceuticals that many have been put on by prescription to begin with, can get that kind of care in the community. So I think that the main point I want to make about 988 is what a great message it is to identify mental health as something that requires a new look and a reliable, safe pathway to care. But we've got years to go before we get close to that place. And, from an advocacy perspective, as excited as we are to promote 988, I'm remiss not to acknowledge that there are communities and contexts in which I would be as anxious about resorting to 988 as I might be anxious about resorting to 911, because the prevalent response may still be a law enforcement response or a response that's discriminatory or re-traumatizing. We hear of, discriminatory and re-traumatizing experiences constantly with regard to people's accessing behavioral health care when they can access it. The level of cultural competency and reliable compassion and person-centric response is not as high a level as we who dream up such things as a robust continuity of care might imagine. And, calling 988, calling for any emergency help may lead to consequences that are generally unforeseen in a moment of crisis, where your family's moment of crisis, even if you call what you think is the right number, may still lead to collateral systems involvement that may linger for years beyond the moment of crisis. So that's the kind of thing that I think we should be having some ongoing conversation about.
Thank you, Vincent, so much. We're going to dig into the questions now. And I have one that regards dispatchers. It's a multi-part question. And the first one is, how are 988 dispatchers trained the same or differently than 911 dispatchers? And also, what strategies are there for states for building out that 988 workforce? And that's for Heather and you.
Heather, do you want to go ahead?
I'll let you take that one. That's not something that we've looked into.
Okay. Well, and I don't know a lot, but that the training will vary from locality to locality. There's not, as far as I know, a standardized set training for 988 respondents, just as 911 dispatch training varies from district to district. And sorry, what was the second half of the question?
What strategies can states adopt to help build out that 988 workforce? And if you know of particular states that are doing well at that, what are they doing?
Yeah, I mean, I'm mostly familiar with the difficulty in building out the workforce here in Colorado. I think that key strategies for building out and retaining a workforce like that have to be to make it enticing in terms of it being a living wage that someone can earn, doing what can be very difficult work because you're exposed to all kinds of vicarious traumatic experience in responding to these kinds of calls. And some of that traumatic experience may be the frustrations in responding to calls for which there is not a holy gold star response solution. And so those folks who step into these roles are pioneers and need to be rewarded and encouraged as such. And they ought to be shown a professional pathway so that they can see that their entry into this world of crisis response has a future. And if they can be shown where they could be 5 years into the work or something like that, that's the kind of local enticing that I think needs to go on. I think that there's opportunity to do collaborative work with local graduate programs with folks who are studying a variety of different associated fields. A lot of students have a great impulse to be of public service in this kind of way. And if they were to integrate some incentives for them, and sorry,
No worries. Were you going to finish that thought, Vincent, before? You're on mute.
sorry about that.
Gotcha.
Yeah, just invaded. So I was just going to say that there's all kinds of creative possibilities, I think, with building sort of practicum work into graduate programs in order to enrich that workforce. But it's the way it plays out locally is going to vary from district to district for sure.
Sure. I'm sorry, Heather, were you about to say something?
I just wanted to add on top of Vincent's thoughts that the data that we have that's looked at pay rates for behavioral health compared to people working in physical health with similar education training time shows that behavioral health is paid much less than other areas. And the pathway, the training pathway has more holes in it. So there are more opportunities for people to fall out of the training path once they start on that course. For example, for most master level providers, they actually have to pay for another counselor to supervise them, whereas some physical health specialties, they get paid to do that work and supervision is included. So I guess building on Vincent's thoughts, I wonder about what behavioral health workforce strategies and pitfalls might apply similarly to the 988 workforce and crisis workforce more broadly. Reimbursement rates being one to look into.
Sure. Before we move to the next question, how much lower are the behavioral health dispatchers, trainees making than the physical health?
We haven't, that's not one that we've looked into when I mentioned that, and I don't know of any research that's looked at that at this point, but that's one of those data points that would be great to have. When I was thinking of that, I was thinking about payment between, mostly it's been done in psychiatry, so payment rates between a psychiatrist and a primary care provider that are providing similar services. There's research shows a disparity, and that's just one example.
So the next question from one of our journalists is, what differences have been observed between text versus calling 988?
Well, one thing that happened is that the answer rates improved dramatically for both text and calling. Text answer, well, both answer rates improved quite a bit. People seem to be reaching out to text more. So the growth in text rates increased substantially more from before COVID to after COVID. Some of the reasons for that might be the investments in 988 and its infrastructure that happened that allowed more investment in these text centers that answer the texts. So those investments, I assume, allowed hiring of more staff, more training, more technology capabilities that let them get to the text messages and answer them more quickly. In terms of quality, I think that's a fair and open question, and one that, to the best of my knowledge, data doesn't exist to answer. But maybe but I'm sure that personal experiences could help inform.
Are there certain age groups that are more likely to use text or to call? Is there any data on that?
Not that I'm aware of. Vincent might know of Colorado data or state level data, but at a federal level, it's not available on the Lifeline, publicly available data.
Yeah, we don't have the Colorado crisis system data available yet for that, but before the establishment of the crisis system, an entity called Crisis Text Line existed, and they have very good demographic data for usage, and definitely skewing toward younger users for text messaging. But as Heather said, I think that the data is not yet available regarding the quality of response, but it is very important to have that text pathway available in crisis, given the heightened opportunity for privacy and being all kinds of different places when you are in crisis and needing to reach out. I think there's a lot of advantage to making sure that we are keeping an eye on how high quality the response can be to a text.
Just in terms of diversion from incarceration, involvement with the court system, how has 988 affected that? And are there still 988 or to what extent are there 988 calls that still end up in the hands of a police officer?
Oh,
yeah.
Go ahead.
Well, I don't have data for that. I don't know. I don't think we've got authoritative data for that. And I would just say that there is that element of risk. That's what I was speaking to. Because 988 is implemented locally, if I call 988 in Denver, my odds are pretty good given Denver's state of developing co-responder and mobile outreach models to de-escalate crises and make sure there's a health pathway in place. But if I'm out in a rural county of Colorado and I call 988, it's very likely going to go to whatever is available for dispatch, and whatever is available tends to be a sheriff in a lot of rural and frontier communities. And unless that sheriff has prioritized crisis de-escalation and health diversion, which varies from every sheriff district, from every county from one county to the next all over the country, you're going to get the same response that whatever the sheriff can deliver in terms of arriving and interpreting and behaving the way they're likely to behave. So there's a huge potential variability out there.
Sure. Go ahead, Heather. I'm sorry. Go on.
Oh, that's okay. I think that's right. I think the main answer is that there's no authoritative data on that particular question, but I think we can assume there's a lot of variation across states based on the development and the models for the crisis continuum. So does a state have a mobile crisis in place? Where is it available? What are the payment mechanisms for the mobile crisis? What kind of responder do they have, like a co-responder unit like Vincent was referring to, where they send out a mental health person alongside a law enforcement? And as I say that, I would expect that there would be a lot of variation. I do think it's important to remember that the studies that have looked at the share of calls that get de-escalated over the phone show that about 80% of calls of crisis is de-escalated over the phone and don't require someone to go out in person.
Okay. So after the mobile unit responds, in terms of treatment and a continuum of treatment, what data is there on that? How 980 is shaping that, frankly, given the shortage of service in community? So what do we know about that?
There are some Oh, you go ahead, Vincent.
Okay, go ahead. I'll speak to Colorado stuff after you.
Okay. I was going to reference some initial studies that came out, which suggest that when people move through the crisis continuum, that's laid out by SAMHSA or something that looks similar to that, the quality of care improves in terms of what people say about their care, and the cost of care decreases. But to be honest, there's not a whole lot out there yet. And I think that's because a lot of these systems are still emerging.
Yeah,
Vincent, you
in
tackle that?
Yeah, in Colorado, I would say that that continuity of care is the aspiration and the experience of consumers who have a crisis intervention through 988 or through another hotline number varies. You know, we have heard what Heather said, reinforced in terms of that 80% successful de-escalation over the phone and very scarce need for transport. But we also hear stories of successful de-escalation in the moment, and then a giant gap in continuity from the moment of a de-escalation from a moment of suicidal ideation, for example, and being able to get your teenager with suicidal ideation in the door to get access to meaningful care of 60 to 90 days in some cases, leaving a family in a state, as you can imagine, of very heightened distress for 60 to 90 days after a suicide crisis call. So that's a huge issue, and I think that there again, that other issue around the substance use access, you might be de-escalated and helped in a moment, but if what you're looking for is a pathway to detox and recovery from a toxic substance, you can't just present yourself today and be in the door for that in the civil setting. And if you can't present yourself today and you woke up with a heroin addiction, the likelihood is that by the end of the day, you're going to be using your substance again. And so it's really important to have that immediate access for folks in crisis so that there's no gap. And that's just totally aspirational here in most places in Colorado.
Sure, we're going to take one more question from the journalist, and then Heather and Vincent, I'd like you to just whip around if there are particular stories that you haven't already mentioned that journalists need to be paying attention to. We'd love to hear that. But this last question says, I'm super interested in what Vincent said about the vicarious trauma problem for people who answer calls and text. Are there any great models for training those folks that prepares them to endure that aspect of the job?
So, you know, I think that training modules for dispatchers in 911 have that kind of training built into it. And, you know, there's not a specific model I would call out, but there's got to be some capacity for debriefing about things. There's got to be some sense of continuity so that your intervention feels like it is a successful intervention that's really reinforcing of an experience of being a dispatcher. And then there's got to be all kinds of ample supports in the workplace for people to have self-care and access to care.
All right, thank you. So Heather, we'll start with you. Just in a wrap up, what would you like to see journalists report more about?
Well, I think I've said this several times throughout the presentation, and I'll reiterate it. I think there are a lot of questions, and I think there's low awareness, and I think there's a system that is working to emerge across the United States, but in different places. So I think people's experiences with the system is something that I haven't heard or seen a lot on. In addition to where these systems are located, how they're working, and what the challenges are in the challenges and barriers in rollout, and how that extends beyond just funding.
Thank you. Vincent?
Yeah, I mean, in terms of how valuable journalism is to evolving things in communities and how local this is, you know, I think we tend to forget that 911 is a local thing too. It is managed locally. It's got a variety of different configurations in different places around the country in terms of who responds to the calls and who's the primary respondent and how it's funded. It's all local. And so an important thing for journalists to look into is how well is it working right here in this community? And what are those stories and what are the hurdles to making that happen? Another thing to look at is how well is the geolocation aspect of this moving along? Because one of the key technical differences between 988 and 911 right now is that if I'm in New York and I dial 911 from my Colorado phone, 911 geolocation systems know that I'm in New York and not in Colorado. But if I call 988 while I'm in New York from my Colorado phone, I'm going to get a Colorado crisis response, and they're going to have to do the calculus of figuring out that I'm in New York and who's my local. It's like there's a whole level of hurdle there that will play out differently from one locale to another. And that's the kind of scrutiny that a developing system should be under. And, when can we confidently tell all populations across the community that when you call 988, you're going to get a safe, healthy, reliable response that is not going to re-traumatize an individual or their family or the community?
Thank you so much, Vincent Achety of Mental Health Colorado and formerly the Equitas Project. He is quite an expert on, particularly on the intersection of behavioral and mental health and criminal justice. Thank you, Heather Saunders of KFF. I'm going to get used to saying that, KFF, and rely on it. This has been a rich discussion, and we really appreciate y'all taking out the time. Okay.
It's been great to
All
be
right.
part of this.
Okay.
Thank you.
Thank
Thanks
you.
so much.
All right. Bye now. Thank you.